what I thought I would focus on today is the spectrum of neurological complications of HIV which are causing problems in the classroom, ranging from the full-blown HIV encephalopathy to the so-called completely asymptomatic children who also have problems, as I'll demonstrate to you. And I'm also going to contextualize it in the broader area of developmental pediatrics, because as you'll see, HIV is just one of the risk factors that many of the children have who are manifesting these problems, and we do actually have to stand back just from the HIV and look at other factors in their lives as well that may be contributing to these problems, and see which of those things we can do something about. So here's the brief outline. As I've said, I'm just going to give you a little introduction, most of which you probably don't need to hear. I'm going to describe a case to you just to kind of put you in the picture, because I'm sure this will ring a bell with most of you, but just to kind of give you an idea of the kind of problems that we see. I'm going to give you some background on the neurobiological and social context of child development, something on HIV encephalopathy itself and our local experience, something on the slow progressors or the asymptomatic children, a little bit on behavioral problems, and then some suggestions for the way forward. Right, so this is a slide I'm sure you've all seen and represents the AIDS burden, and we've got a very fat tummy, basically. And juxtaposed against this is our physician density. And so as you can see, this is what we call the inverse care law, where those who need the care most are the least likely to receive it. And so the reason I put this up is not because you need to have this information, which you obviously have, but to say that so the children who are accessing care and the children who are going to ARV clinics are going to very busy clinics, and people are seeing many children every day, and so the time and the energy that one has for looking for things other than the child's medical health is quite limited. So one needs to have a high index of suspicion and have a few tools and specific hooks, things that you know that you need to look for to try and pick up the problems. This really just represents the dismal figures around ARV access in South Africa. Obviously, it is getting better, but it is still far behind where we would like to be. And as I've said, it has got a lot better in the last 6 to 8 years. And in the Western Cape, we're lucky. Children have almost universal access to ARVs. It's not always as early as one would like, but again, that is getting better. So patterns have changed very little over time. UNICEF in their 2011 report for sub-Saharan Africa report that the number of children in the 0 to 14 age group receiving an estimated to need antiretroviral therapy and the percentage coverage. So in brackets is the number of children estimated to need it, and this is the number of children on ARVs, and this represents 21%. So and given that we carry the 87% of the burden of the world's HIV positive children, what we're seeing is a huge number in absolute terms of children who are not accessing treatment, and they are the children who are at worst risk of the neurological and in fact all the other medical complications of HIV. So this is not a problem that we're going to see going away soon. The effects of HIV in our context have been well established in the kind of general medical terms, but the less quantifiable effects on morbidity, including their cognitive function and behavior, is much less defined. And this is just a reminder of the context that many children live in. This is less than 20 minutes drive away from Red Cross Children's Hospital, this sort of bastion of tertiary medicine. So the studies describing specific cognitive impairments in HIV children have highlighted that there are certain domains which are commonly affected. So visual perceptual skills and visual motor skills, attention, executive functions, memory and language. Now you think of yourself sitting in a classroom, especially in the younger years, and your teacher's teaching you a literacy subject, and they give you something to remember, and then you need to sit down and do the work. So what do you think is going to be a problem here? If you can't remember what the instruction is, if you weren't concentrating long enough to actually attend to what she was teaching in the first place, and you're having problems with expressing your issue or expressing your answer verbally, you're going to have problems in the classroom. These are all domains that are critical for managing in a classroom situation. So you may be able to manage on the street, and you may be able to manage with all the kind of social domains, which is fine, but in the classroom, these are the ones that cause problems. So studies have also reported an increase in behavioral problems in HIV-infected children, and I'll talk more to that later. So here's our case. OM is a 10-year-old girl. She was brought in by her foster mother because she was failing grade 3. That's why they came to visit us. And she'd been, on further questioning, it seems that she actually hasn't passed a grade. She'd just been promoted through on age criteria. She had been commenced on ARVs only at 5 years of age, and now she was on a second-line regimen, which doesn't speak well to her general control. At diagnosis, she had a high viral load and a low CD4 count, although currently her viral load was suppressed with a reasonable CD4 count when we saw her first. So of interest to her developmental milestones, she walked beyond 3 years of age, and our outside limit for when you should be walking is about 15 to 18 months. So 3 years is really quite delayed. She said her first words at 4 years, and we usually expect children to start saying words with meaning between 10 months and 12 months. So clearly she's had problems from early on. When we examined her, she was a small child, globally growth restricted. Weight and height were below the 3rd centile, and her head circumference was below the 3rd centile, so she was microcephalic, and the head circumference was out of keeping with the rest of her growth. She did have normal limb tone and, in fact, a normal gait, but had very brisk lower limb deep tendon reflexes. And I wonder how many of you have the opportunity to do a neurological exam in a normal, busy HIV clinic. Also important was that she had scarred membranes on examination of her ears, but no active otitis. So we managed to get a neuropsych evaluation. We don't have this routinely available to us, but we do have a group of students who are supervised by the Department of Psychology, so we can get on certain children. And so on formal testing, her full scale IQ is 71, and to give you an idea, the normal is considered 100, and and 70 is considered borderline intellectual disability. Her verbal IQ was very low at 55, and her performance IQ again in the borderline range. She didn't have specific fine motor problems, but again she had specific problems with working memory, processing speed, and she really struggled with more complex tasks and attention. So when you're needing to problem solve, and again this is a key skill in the classroom, those are areas which are problematic. So nothing more on her for now, but it just gives you a bit of a picture of what we're looking for, and I'm sure she's not an unfamiliar picture to most of you. So her investigations were actually completely normal. So now I'm going to talk to you a little bit about early child development and just demonstrate to you how important it is that you put the building blocks in place for children when they are young, because what we are seeing in the older children and the adolescents are a result of what happens early on. So it's not to say that we mustn't intervene and do something about the older children, but really the focus needs to be on trying to support systems that can prevent these risk factors impacting on children. So early child development refers to the child's physical, cognitive, social and emotional development from a prenatal period, and that's key, right through to 8 years of age. And just a little reminder that development occurs with sequential acquisition of skills in 4 areas. Gross motor is the one that people most commonly think about, because especially in small infants, the walking, running, those are the things that parents tend to focus on. But fine motor development, developing pincer grasps, hand use, manipulation skills, hand-eye coordination. Language is self-explanatory, but it's not only your expressive language, it's also your understanding, your receptive language, and non-verbal communication. And then your psychosocial skills, and these are more your activities of daily living. So how you interact with other people, learning to eat by yourself, being toilet trained, all of those kind of practical things, and they obviously there's obviously quite a lot of overlap between those. But it's a dynamic process, and it spans a huge range from complete dependency towards growing independence. I'm going to show you just a couple of videos, and they really are not important in themselves. It's really just to illustrate the huge changes that happen in early development. Okay, so this is just a little baby, okay? He's not mine, but he's exploring his environment already at 3 months of age, but it's in a very poorly directed way at this stage. He's really he's reaching out, but it's very, very poorly directed and non-specific. He is putting his hands in the midline and just sort of kicking randomly. He isn't able to sit by himself, which you wouldn't expect at 3 months of age. Right, next. So this child is actually just under 18 months, and you can see there's a huge amount that has happened in that time. So it isn't the same child, but it's a sister. So she is sitting by herself. She's exploring objects in a much more sophisticated way. She's able to actually manipulate objects. She's got object permanence. She understands that when you can't see something, it's still there. She's asking for help, even though she isn't actually expressing it. Okay. So what I just wanted to illustrate with that is the huge amount that goes on just in the first year of life. How that child from the age of 3 months, where there's a lot going on, but it's really quite limited, to 18 months where there's a little person there with a lot going on. And this slide really just illustrates, this represents fetal development, and these bars represent the sort of maximal time of development for different organ systems. And you can see across the top here is the central nervous system. And the thing about that, as opposed to all the other organ systems, is it spans the entire fetal development process, so the whole 9 months. And for most of that time, the black bar is, or the dark brown bar is where there's actual structural development going on. So you can see that the opportunity for external factors to have an influence on the central nervous system during fetal development extends over a very large period. So what occurs before birth and in the first few years of life plays a critical role in health, cognitive and social outcomes. And it's the most intensive phase of brain development throughout the lifespan and the most critical time in human development. So I hope I'm getting my point across. One last slide on that front is these three panels represent the brain at different ages. So up here you've got a neonatal brain. So this is in the first 2 to 3 weeks of life. This brain here represents a brain of a 1-year-old, and this represents a brain of a 2-year-old. Now, can you see the difference between this brain and this brain? It's huge. There's not only size, but the complexity of the structures and the maturity of the cortical folding and patterning really just as an illustration of what happens in the first year. And this is between year 1 and 2, and you can see there is growth and there is development, but it is not quite in the same scale as between the first month and the first year. So this is a more traditional framework for understanding how factors may affect a child's development, and it's a model which we don't really subscribe to anymore. So although these factors are important, we know now that very rarely is it just one factor acting on a child, and that usually there are multiple factors which interact with each other and cause problems. So epigenetics is an important concept to start understanding, and what it means literally is outside or beyond genetics. And what it means is that genes can influence your vulnerability to certain disorders or diseases or stresses, and your environment can actually alter our genetic code. So this can have positive or negative effects, and I'm not going to talk into that in more detail, but just to say that 2 children given the same stresses will react differently because they've got different vulnerabilities, different genetic makeups and different personalities and different backgrounds. There are 3 translational processes, and what I mean by that is there are 3 factors, the key factors which affect how one of these stresses or factors will be affected in the child. So this can be the extent and the nature of the effect is most critically affected by timing, and I've talked to that in the previous slides. Co-occurring and cumulative influences are key, and this is especially important in our group of children who are HIV positive. And then differential or biological reactivity, and that really relates to how a child reacts in a situation. So to put it in summary, you've got, say for example, you've got 2 children who are both 2 children in a creche, and one is very emotional, tends to react when other children push them and shove them. They get into fights easily, they are impulsive, they tend to jump off the jungle gym and crack their arms, and then they tend to get very upset by it. You can see that their kind of whole emotional environment is going to be very different from the child who's a lot more kind of laid back, and if somebody bumps them, they don't worry too much about it, they don't take it personally, their stress levels, their hormone levels aren't going to be raised, and all of that does interact with the other factors. So here's another example of how these things can be affected. So iron deficiency is well described as being a factor which can affect child development. And it's been shown to affect actual myelination. So your white matter is the sort of conduit system which takes the messages from the control centers in your brain down to your arms and your legs, your mouth, your tongue, all the organs which actually are able to do what you want them to do. And like an electrical wire, if you don't have insulation around it, and the myelin represents that insulation, the messages don't get through as effectively or as quickly, and so children do have delayed development if their myelination is not well developed. It also affects dopamine receptor density if it's present, if iron deficiency is present during sensitive periods, and your dopamine system is very, very central to your fight or flight response. It's also iron deficiency in this period is also important in the consistency, availability, and quality of primary caregiving relationship, and so development. So these things can interact with each other, and the cognitive and behavioral sequelae are well documented. So it can be quite complicated. In South Africa, we have many risk factors for intellectual disability. And ill health, and that's the group where HIV fits in, is just one of them. Substance abuse is important, growth and nutritional factors are extremely important, and then cultural and social factors can also play a role. And this classroom just illustrates the conditions that many children have to go to school: is crowding, uncomfortable seating, inadequate resources, etc., etc., etc. So one slide on growth and stunting, because it's very important and it directly relates to our children with HIV. Stunting has been shown to have a profound effect on later developmental performance. And I think it is in part because it represents nutritional deficiencies, but it also represents the kind of social environment that a child comes from. So a child who is stunted and has poor food security is also more likely to have a mum who's depressed, is less likely to have a mum who is well educated, able to provide good early child stimulation. All of those things start coming into it. So it's a kind of proxy for a whole lot of things. And in a lot of many good studies, and this study, it comes from 2005, but a recent big early childhood development study done in multi-center study across South Africa has been shown, in fact, to be higher than that. In areas we have up to 30% of children in the poorer areas are stunted, which is a staggering figure, and it's something that one definitely needs to address. So this really just represents graphically what I've been talking to, how all these factors interact with each other and can affect a child's development and school performance. And clearly there's evidence that the compounded effect of poor maternal nutrition and toxin can be particularly difficult. And unfortunately in the Western Cape, we don't really have different water, but we do have an epidemic of substance abuse, and we really are quite a capital of fetal alcohol syndrome, and methamphetamine exposure is becoming a very big problem as well, and children in the farms are often also exposed to organophosphate. So we've got a rather toxic cauldron of factors in the Western Cape, and some of these will relate to Joburg as well. This is just a reminder of what children with the full-blown syndrome of fetal alcohol syndrome look like. These wide epicanthic folds, smooth philtrum, but most children who are affected by alcohol exposure don't have the full-blown syndrome. They have what we call fetal alcohol spectrum deficits, which relates to a very similar spectrum of cognitive problems to the children who are finding who are HIV positive, and behavioral problems. So here, studies are increasingly coming out showing basically that your increased exposure to alcohol means that you're going to have increasing problems. So it's not just some people get hit by it and get the full-blown syndrome and others don't have any effects. The chances are there are going to be some effects. They're just not always as obvious. And there are areas in the Western Cape where between 20 and 30% of children have been diagnosed with fetal alcohol spectrum disorders. Sorry, are you not hearing me?
Most can.
Okay, sorry. And then again, the genetic factors come into this, and individual susceptibility. So experience affects individuals differently, and approximately 15% of children are more highly biologically reactive to their immediate social context, and that was what I was describing earlier. And this has bivalent effects over lifetime. So children, what has been shown is that children who come from poor socioeconomic backgrounds are more likely to be exposed to negative experiences, and so the pathways and the hormonal environment that reinforce those negative experiences become laid down and embedded early on, whereas children who come from good environments tend to have more positive experiences, and so they tend to have a much more positive hormonal environment embedded and have much better outcome further on. So it can work in your favor or against you, but the vast majority of children that we are seeing in the HIV context have a lot of psychosocial stresses and would fall into the first group. And the differences in developmental trajectory will widen over time. So it's that whole concept of the rich get richer and the poor get poorer. And this is just an illustration of it. This is a local park near to me, and both these children are very impulsive. That is my daughter disappearing at a high rate. They're both on a balancing beam, and they're both about 3 at the time. And this little boy lives on the street, and this little girl lives in a middle-class house in the suburbs. And because he lives on the street, he's much more likely to be exposed to violence towards his mum. He's more likely to be cold at night. He's more likely to not have enough food. Whereas the other little girl is going to have 3 square meals a day. She's got a warm bed to sleep in. She's got a school to go to where there's a program which is developmentally appropriate. And you can see how 2 children who can live in really exactly the same geographical area can have an experience which is worlds apart, and it's just rather sobering. But there are some protective factors, and we're really moving in the right direction. So breastfeeding is a powerful protective factor, and our move back to exclusive breastfeeding, I think, is a major victory in that front, and it's something that I hope you're all supporting actively. Maternal education is the other factor which really seems to be key, and that really is self-explanatory. You can see that if mums are educated, they are much more likely to feel empowered, much more less likely to be depressed, and much more likely to see the value in continuing and supporting their own children's development and education. So these are things to work towards, because they independently have a positive effect on children's development. And here this illustrates it graphically. Our children who have got protective risk factors are more likely to follow the top trajectory for their developmental outcomes. Those who've got negative risk factors, and if you've got negative risk factors but you've got some protective factors as well, it can lift you up. So there are always going to be exceptions to the rule. There are always going to be children who are okay despite terrible environments, and so it's not all gloomy. You've got to be able to foster those children's resilience and foster resilience in the children who are struggling. So really the summary of that section is that early childhood is a critical time in human development. The factors affecting development relate to each other in complex ways during particular periods and across time. And it's really important to identify protective factors, across populations, but individually in the patients and the families that you're seeing, and implement appropriate interventions, especially in vulnerable groups, of which ours definitely is. So now to go on to HIV encephalopathy itself. By definition, it refers to the disease, damage, or malfunction of the brain caused by HIV, and it's the kind of what is the word? It's the kind of flagship neurological complication of HIV. There are many neurological complications of HIV, and what I'm going to focus on today is the spectrum of of neurocognitive disorders caused by the virus that affects children so hugely in their daily life. The other effects, such as stroke and the neuropathies and myopathies, are usually quite clear on physical examination and then can be addressed. But these are the silent disorders, the ones that we don't always pick up, especially if we're not looking for them specifically. So I'm going to spend some time talking about this. Currently, HIV encephalopathy is classified as a stage 4 AIDS-defining illness, and this reflects the severity of the disease. And this again represents the course and subtypes of the disease graphically. Here you've got, this pointer's getting tired. Here you've got the normal developmental trajectory, and here's a child with the so-called static course, and this is probably the majority of children that you're seeing now. These are children who have who don't necessarily have the obvious physical findings of HIV encephalopathy, but may have the cognitive effects. And you can see that even if they are still progressing and developing, they're still behind normal development. And this is difficult to catch up, and not many children do. The more severe course is much less common now, even in Cape Town, although we do still see it. But with the rollout of ARVs, this progressive course is really much less common, happily. Now, this represents the typical neuroimaging findings that you see in HIV encephalopathy, and we're not seeing it in all of the children who've got HIV encephalopathy clinically, and it is a clinical disorder, so you don't need imaging to diagnose HIV encephalopathy. But this is probably the most typically described findings, where the child has a small head. They have atrophy when you look at the brain matter itself, and basal ganglia calcification. So these enlarged ventricles don't represent hydrocephalus, they just represent fluid taking up the space where brain should be. And these are some more subtle findings, which we find in a much larger group of our children now, where there are just more subtle white matter signal changes and sometimes volume loss. That is what we're seeing more commonly now. So really, I'm going to talk a little bit now about our experience with a group of children who've got HIV encephalopathy in our Cape Town clinic. And these come from a specific HIV-Neurology clinic that Dr. Walker and myself set up in 2008, and which we've been running since then, with the aim of seeing and diagnosing children with the neurological complications of HIV. So up until about April this year, we'd seen 134 new children. Now it's closer to 150, but we documented them over that period. And of that 134, 85 were diagnosed with HIV encephalopathy. So that is a big group. It is still a clinical problem. And these were not diagnosed based on, so your criteria for diagnosing HIV encephalopathy you need to have at least microcephaly, or the long track signs, which is increased tone, increased reflexes, and an abnormal gait, or you need to have evidence of neurocognitive deficit less than 2 standard deviations below the norm. And we aren't able to get, for the vast majority of cases, we're not able to get formal neurocognitive testing on our children. So all of these children are diagnosed purely on the physical grounds, which means they're probably on the more severe end of the spectrum, which probably means that 85 out of 134 is an undercall on the number of children who should have the diagnosis. The ages ranged from 10 months through to 13 years, right across the spectrum. Half of them had small heads, and 2/3 of them had long track signs, and that's probably not surprising given that those were our diagnostic criteria. We found that 2/3 of them had delayed early motor milestones, so this is delayed walking in essence, and 56% had delayed early language milestones with no information on 15. Of those who were, so only 37 were of school-going age, but of those, over half were already repeating a grade. Okay, so this is a big problem. The children are struggling. So additional diagnoses, these are important because these are often things that you can actually treat. For example, 20% of them had at least one seizure, and of those, most of them had active epilepsy. 37% of parents or caregivers reported that there being behavioral problems, and nearly 20% had a formal diagnosis of ADHD. But quite staggering and a little bit unexpectedly was that 40% had active ear problems. So 8 of them had acute otitis media and 28 had chronic suppurative otitis media. So these are children who were not being actively managed by an ENT service and who had not had hearing tests. So we did go on to do hearing tests, but it was just a sort of salient reminder of the things which aren't necessarily developmental or brain factors, which can impact on your development and certainly on your school performance. Clearly, if you can't hear what the teacher's saying, it doesn't matter about your attention and your executive function. Okay, so the other factor which really has come out from our work with this group is that with very few exceptions, the children with school difficulties had not disclosed their HIV status to schools. And I'm sure this is an experience that you share as well. Parents, the stigmas still are out there, and although there is a lot of work being done on that, parents feel that their children are being discriminated against in the schools, and so they don't tell, and so they are not actually willing to ask for help around other things because they don't want to draw attention to their children and maybe have them found out. And so that is something that I think is really important to address with people. So all except one of the children in the group were already on ARVs, but many of them had been started late. Again, this is just a reminder of the kind of findings that you can find on brain imaging, but it's not important to do the scanning to make the diagnosis. And this is the spread of imaging findings that we found with our children, and about 25% had the typical findings of atrophy and basal ganglia calcification, but a much bigger group had the more subtle white matter, volume loss or signal change, and a full quarter had completely normal scans. And these are scans done in a tertiary hospital and reported on by experienced neuroradiologists. So the chances that the findings have been missed is quite slim. And really what this represents is that the damage is happening on a functional level and on a level which isn't always picked up on gross structural imaging. And that we are demonstrating more with more refined techniques, and I'll speak to that in a minute. So with the anticipated decrease in childhood mortality, the impact of HIV-associated disability is becoming increasingly important. And so what about the group of children who don't have HIV encephalopathy, but have cognitive impairment? So a little word about the slow progressors. These are children who are vertically infected with HIV, but who remain clinically and immunologically stable for a long period. They're receiving no or minimal therapy as defined by single or dual nucleoside therapy before the age of 10 years, and they've consistently maintained CD4 counts above 25%. And amazingly, there are some children out there who fall into this group. In South Africa, as many as 35% of all infected children are believed to meet the criteria for slow progressors. And this data comes out of the kind of pre-ART era. And clearly we're not going to have as much of an opportunity to identify these groups because we are starting children on ARVs early, but that shouldn't be an issue. We should be starting them early. There's little information is known about this group of individuals in terms of their development or cognitive outcomes, so we decided to have a look at them. So this is a pilot study from children aged 6 to 16 years, and they were asymptomatic perinatally infected, HIV-infected children. And the results indicate that cognitive function and white matter integrity as defined by DTI, and DTI looked at the integrity of those white matter tracts that we talked about earlier, rather than the gross structural changes. And the asymptomatic children performed poorly on performance and verbal tasks of the general intelligence tests, as well as tests of visuospatial processing, visual memory, and executive function. So you're hearing the theme here. It's coming out again and again. It's come out in the children who are known to be affected and who are diagnosed with HIV encephalopathy. But what we're seeing now is that it is coming out in a clinically important way with children who are supposed to be completely well and asymptomatic. Furthermore, parents and caregivers reported behavioral problems in the clinical range. So this group of children tended to be more depressed and anxious, and it probably is because they have more insight about their disorders. This is really just a picture which represents the findings of the study and shows pictorially where those white matter tracts are situated and are analyzed. So the bottom line is that despite a child being described as asymptomatic, HIV infection is still has an impact on the central nervous system, unsurprisingly. It does cause deficits in certain cognitive domains, and it really tells us that it's important to investigate specific cognitive domains and ask about behavioral symptoms. And if you don't have access to neurocognitive tests, ask for school reports, because they can have behavior problems. And if you have behavior problems, especially attentional problems, you can be struggling in the classroom. Another arm of the same study particularly looked at adaptive functioning. So they looked at the same group of children. They looked at the relationship between the child's disease severity and their psychiatric symptoms and functioning. And surprisingly, children who met criteria for ADHD scored much more poorly on health ratings and measures of academic and social functioning. So what does treatment do? Does it help? Antiretroviral treatment has been proven to prolong survival rates of children suffering from HIV and AIDS by promoting normal growth and development. It has dramatically decreased the rate of HIV encephalopathy in the States from between 35 and 50% to less than 2%. And this is an intervention graph that you would like of any study that you do, because this represents the rising coverage of ARVs, and this represents the rates of HIV encephalopathy going down, but it isn't zero. There are still some children who are vulnerable. So in under 15 years, heart seems to improve or even reverse some of the neurological pathology seen in HIV positive children, but that is controversial. Some studies have shown that it does, and some studies have shown that it doesn't. And even when children are virologically suppressed for a prolonged period, improvement is not guaranteed. And as most antiretroviral agents do not cross the blood-brain barrier readily and are postulated to allow a consequent viral reservoir in the brain. So this is just one of the theories or postulates around why the neurological effects respond so poorly to treatment in the long term. I think the key is to get children on ARVs early. So what about treating older children? Because we've got very clear guidelines in place now that allows almost universal access for young infants to go onto ARVs. But what of the children who've missed the boat? What about the 4-year-olds and 5-year-olds who still aren't on ARVs and don't meet immunological criteria? What about them? What if they have milder neurological problems? Should we be starting them on heart? So the WHO guidelines, as I've said, are for the children for children outside of the 2 years of life remain unchanged, and these guidelines don't affect the vast majority of children living with HIV in our context. So I think that what we can take away from this is that the HIV infection still does have an impact on the CNS. It's causing deficits in certain cognitive and behavioral domains. Asymptomatic children may have been classified as such due to their scores on global measures, and they're not picking up the more specific problems which may have a very significant impact on their schooling and outcomes, and it may have a profound effect in their schooling environment. So the role of ARTs to both children and adults with HIV has improved the outlook for children in South Africa, but for the older children less so, and also often unable to disclose to the school. Parents are reticent to seek help for their children with learning difficulties or behavior problems in the school setting. They are unsupported in a system which is focusing on their medical needs and not adequately recognizing these less life-threatening issues. And there are more and more children who are reaching school-going age with improved treatment accessibility, and we've got to be picking up these problems. So HIV encephalopathy is still a significant clinical problem. It's not being diagnosed well. All those children that we saw in our HIV neurological clinic who we diagnosed with HIV encephalopathy had not been diagnosed before, and they'd been attending specialist ARV clinics. So no one is doing neurological exams because they don't have time and because they're not thinking about the outcomes. There are often cognitive and behavioral manifestations, even when HIV encephalopathy is not the diagnosis. Comorbidities are present in many of our children. We need to look for them. We need to look for nutritional problems, food security, and non-disclosure is putting our children at higher risk. This is just a little reminder of the interaction between all these factors, and just not to lose sight of that, because it is, if we just act on one area, we're not going to be able to address the problem. So some practical take-home points. Do the head circumference. There isn't a head circumference chart in the new Road to Health card booklet. But please try and get them put into your files at clinics, because if you don't measure the head circumferences, you won't know that the child is microcephalic. So do it at birth and do it 6 monthly thereafter. Try and do developmental screens and surveillance. There is a limited screen in the new Road to Health card. In the Western Cape, we have a slightly more thorough screen which is available at the primary healthcare clinics for time to immunization visits, but it's not universally used. And if you have a few key points to pick out, then you're more likely to pick up problems. Treat the treatable, so treat epilepsy, and sodium valproate is the first line for epilepsy in children with HIV. But beware of the children who are on efavirenz particularly, and the interaction. Manage their behavior and consider medication. There are no contraindications for the use of Ritalin or methylphenidate in children who are HIV positive, and it can make a difference in the right children. Remember the side effects of antiretroviral, so particularly efavirenz is a culprit and can cause psychiatric and cognitive problems. So, and our genetic pool of children seems to have a particular vulnerability to slow metabolizing of efavirenz, and so we do actually have a large group of children whose levels are higher than they should be. It's worth checking levels if you're worried, and always check the ears, and always have the hearing tested if you're concerned. And remember that this is a family disease. Who ask about the siblings and look at the whole kind of social context. Just some additional thoughts. The more adult spectrum of HIV-related CNS compromise, or the so-called hand spectrum, needs to be actively sought. We don't have clear terms for this in children, and something that we need to think about. And psychiatric disturbances are under-recognized and under-reported, so especially in the adolescent population. Thank you.